Okay, so I'll just introduce this now for the sake of the recording, which is that it's May the 8th today, I think. No, yes, May the 8th. This is Rick Davis. We're meeting with Dr. Richard Wassersug, one of the foremost, certainly the foremost peer expert on estradiol, because he's been on it probably longer than anyone else we know, and also to patients who use or are considering using E2, and Al Latimer and Steve Schuler. And we're just going to have a discussion around some of the nuances of E2. So with that, I'm probably not going to say very much, and I'll turn it over to Richard.
Okay, so I guess I should say a little bit about my own background. I know you guys may know this; it's not hidden. I was diagnosed at age 52 with prostate cancer. My first PSA test was 19. I had a radical prostatectomy on my birthday when I was 53 years old. I'm now 78 years old. So I've been in this situation for a while. My PSA started climbing immediately after the radical prostatectomy. I went for salvage radiotherapy. My PSA kept climbing, but was always low at that point. And I started hormonal therapy over 20 years ago. Started on Lupron. Did not like the side effects. Knew of a group that was studying and exploring the estrogens as an alternative to the LHRH drugs, agonist drugs like Lupron, and decided that I wanted to try it out. And I've been on transdermal estradiol almost continuously for over 20 years. And here I am.
What dose?
So the dosing is going to be a big part of the discussion.
Okay.
Because there, as you know, and Al, I'd like to, but let me say before we get into that, Al, I don't know enough about your medical background. Can you give me a little bit of quick history on your situation?
Okay, I was diagnosed in 1995 with a PSA of 19. Does that sound familiar? I had a radical prostatectomy in December of 95 at Johns Hopkins. My PSA started rising again almost immediately. I was seeing an oncologist at Johns Hopkins. They said, well, as long as you don't have any evidence of disease, we don't care what your PSA is. So my PSA kept rising and rising and rising and rising. And when it got to 200, I was at a prostate cancer seminar with Dr. Charles Myers was there giving a talk, and Dr. Logothetis was there from MD Anderson. And we sat with them at lunch and told them my PSA was 200, and they fell on the floor. So I switched from MD Anderson to MD Anderson. They put me on Lupron, and my PSA went undetectable, and it stayed that way for 8-9 years. But I was very sick of Lupron, and I wanted to try intermittent therapy, and Dr. Logothetis refused. By that time, Dr. Myers had cancer, prostate cancer also, and he opened his own clinic. So I went to see him, and he put me on the estradiol patches in 2007. So I'm almost as long on it as you are. And my PSA stayed undetectable until about 2017, 18, somewhere in there. He retired. I added Xtandi to it. My PSA went undetectable again for a few years, but then it started creeping up again. And I've been through a whole series of things since then, including Pluvicto and chemotherapy.
How are you doing? How are you doing now? Are you asymptomatic, or do you have symptomatic mets?
I have Mets in lymph nodes only. And I have not had my most recent treatment was Pluvicto in December. My PSA got down to about 6 from, I must say, well, anyway, I don't know how much more I need to go into. My
How old are you?
75.
Okay, so we're about close to the same age.
We're about the same
Yeah.
age.
Okay, you've been through it, and that was further along than I am. Okay, so Steve, you jumped to the question dosing, and
Yeah,
this
I mean, because I'm curious about the estradiol as primary versus medium add-on, but
right. So it's low dose ether to replace the missing estrogen that you get with secondary to testosterone suppression, or it can be high dose in order to be to testosterone suppressing. So I follow closely the patch study, which you're aware of, which is the only large-scale randomized controlled trial comparing an LHRH drugs like Lupron and Zoladex, or Lucrin as they call it in England, to transdermal estradiol. We're all on the same page of why we're using transdermal estradiol. You don't want first pass estrogens to the liver where clotting factors are produced. The status is, and I think Rick made reference to this, but I know this directly from the patch team. They expect to be publishing this fall the results of the patch study. Now they're actually 2 years behind when they first told me they were going to publish it. They expected in the fall of a year. That is a good sign, because if you're doing a head-to-head comparison with overall survival as your outcome, and you're not getting any evidence of one arm of the study showing a lot better survival or a lot poorer survival than the other arm, then you have to run the study that much longer to know whether you have a difference or not. So the mere fact that the study is running longer is circumstantial evidence that transdermal estradiol is going to prove to be relatively comparable to the standard LHRH drugs for overall survival. And by the way, cut me off if I get too academic sounding. You all understand I'm not an MD. I'm a research scientist, but happens to be on these drugs. But if I'm talking too fast, or cut me off. So here's the latest, and Rick hasn't heard this, but what's going to happen, I believe, and this is my own speculation, is that estradiol is going to prove to be cheaper. It's going to prove to be easier to manage than a bolus injection or multiple bolus injections, like every month if you're on Degarelix or Spermagon or whatever. And by management, I use the gel product, Estradiol. I much prefer it over the patches. I'll tell you why in a minute. But I'm seeing this now from lots of patients, and Steve, you're just one of them. I get a couple every week of patients wanting to know, how do I manage it? They've read the papers. I've talked to them. Here's the papers you want to bring to your doctor, or the references. And the doctor's saying, yeah, I'm willing to try it, but I don't know how to dose it. And when the patch study comes out, this is going to be the biggest question. How do we manage it? Not, is it safe and is it effective? That's my guess. I mean, I'm pretty sure the safe and effective stuff is going to come out solid, but there's a real question. And with another patient, like 2 patients actually, we're looking into the management, and we haven't published this yet, and I don't know whether we will actually publish it, but it turns out the variables are enormous here, and if I take a grand view, it is actually going to have to come down to personalized medicine when we talk about we got to be following each individual patient situation to consider what is the best. And to say, Steve, I hear that I want to get my PSA, my serum estradiol level to this number. It's going to vary from every single patient. How do we know this? Well, one of the 2 patients I'm working with has a nuclear physics and engineering background, and he's incredibly quantitative. Hello, John. John,
Hi, Richard.
hi.
Nice
So
to
I'm
see
talking
you.
about challenges for proper dosing of transdermal estradiol. And I don't have a list in front of me, but I'll run you through a couple of things. Some of this stuff is buried in the patch literature for going back a couple of decades. Some of it even predates transdermal estradiol for early explorations for steroid drugs back in the 1960s and 70s. And one of my collaborators here on this project had dug up these papers. And it turns out that steroids are fat soluble, they're absorbed by the fat. And where you apply it on your body is going to vary greatly in terms of absorption rate, depending on how much cutaneous fat you have. When the products were produced for women, they wanted you to put them on your thigh and in your abdomen. Why? Because that's probably the standard place that's easy to reach, that doesn't get in your way. But I can't find in the literature evidence that when they were producing these products for women, that they actually, assessed how much fat was subcutaneous. And in fact, going back about 20 years ago, there was a urologist in Argentina who published one paper. Can't recall his name, but I was in communication with him back then. And his contention was, we should have put the patches on. He was exploring this in South America pretty much on his own. And I had not seen, I don't know if he's still alive even. I don't know where this went, but he was exploring putting them on the scrotum. Not because the testicles are nearby, but because the scrotum lacks any cutaneous fat. That's why we have a scrotum. We can cool the testicles down. And it is going to turn out that if you're trying to reach a certain serum estradiol target, which itself is a question, it's going to make a difference whether you put it on your forearm over the bone where there's next to no fat, or on a big fat belly. It's going to make a big difference if you're a fat guy or a thin guy. So you're going to want to monitor it. There's not going to be one number that's right. And I think that will honestly turn out to be a bigger challenge for the doctors in a one-on-one consult with their patients, is how many tests, how many blood draws do you want to take? I'm up in Canada where we pay for each other's health care, and the doctors are going to say, you can get a PSA test every week, but that may turn out what's going to have to happen to dose it correctly, appropriately, to not get too high or too low. So let me make a sidebar on that. Too high means you're so high that you're in blood clot range. And how do I know what the right range is? We don't know. That hasn't been looked at specifically. But we know the heuristic I use for myself is I don't want to be above the normal high point for women pre-menopause. That is during their cycle. Because typically women before they have menopause aren't getting blood clots unless they have some sort of coagulative disease or whatever. So, and I have peaked out above that 2 or 3 times over 20 years. And then I just drop down. I use a gel because I don't have to count patches and say, oh God, I'm going to change these number of patches on that day. I can just squeeze out a little less for the gel and put a little less on. So that doesn't make it any easier for you, Steve, if you're looking for a simple answer. But I don't think that it's
Yeah, no, that's really helpful. I guess the other question I would have then is, are there any other monitoring or assessment tools than serum estradiol that are helpful?
Well, from the bottom, if you start growing hair on your arms and legs again, you're too low, right? And if you
I mean that a doctor would use.
No. I mean, the only way to know what your circulating estradiol level is to get some blood out of your circulatory system and measure it. But estradiol is 100 times more potent. It binds to its receptors at 100 times what testosterone does. And one of the times where I peaked high, I realized I had put the estradiol on my arms right before I went for a blood draw, and I had rubbed it on like this, the gel, right? And they put the needle there, okay? And that it has a relatively short half-life, but this is like an hour and a half later, and they were picking it up right from my skin. I mean, it is that it can be that high. And very quickly. So one needs to also be standardizing how they're applying it. And it's going to make a difference if the guy is. So when you start on it, you have to know, get pretty regular blood draws. And in fact, there's a personal essay I published about that. And I think it's I mentioned on an earlier recording that I did for AnCan. But I think you will have to be really standardized. in terms of application, not to get too high or too low. But it's going to vary from person to person. It's going to vary a lot. So all right, maybe again, go on a small tangent. What are some of the variables? So one of the variables is if you already had a history of venous thrombosis, you're probably at high risk and shouldn't be exploring this. If you have the genetic profile that suggests that you have an estrogen-sensitive version of prostate cancer, an ATM or BRCA2 gene mutation, you probably shouldn't be exploring this. I would say, I think the clinicians would agree on that for sure. I don't think people have allergies to it or anything like that, but what can affect it is not just on the skin where you apply, but this is where it gets complicated. I've mentioned this occasionally. It's not in our book on androgen deprivation therapy at all, but the gonadal hormones regulate their own receptor density. So just to make this super complicated, if you're actually applying exactly the same amount on your skin over time, you're not necessarily going to be able to get a stable serum concentration. Why? Because it regulates its own receptor density. And in fact, that we know that from women. We don't have data particularly on that directly. There may be some cell culture data that I don't know, but for humans. But just applying exactly the same amount, and then you get a blood draw, like say once every month or 2 months, you may not find that the serum concentration is the same because it took a certain amount of time to be absorbed through the cutaneous fat. There could be other factors, dietary or whatever, affecting the clotting factors, etc. But the receptors, the system is designed to actually, for women, there's nobody working on this. It's going to be years before that. But the system is designed to have estrogen cycle, right? And as long as it's cycling, you can maintain a menstrual cycle, and you can maintain the system. Okay, but when the estrogen starts to drop naturally with women with menopause, the receptors start to go down. You eventually lose the receptors, and then giving women back estrogen can't turn the system back on again. As long as it's fluctuating, you could, right? So if you think about this is already known from women. It was known from the relatively early days of the pill, when they started saying, we can control women's menstrual cycles with this dose, and they found it didn't work. If you look at the packaging now, it's actually 3 weeks of an estrogen and then off. And so it actually is designed, you take it daily, but it's real, at least some of these products, as I know, are designed to pulse. And we may get to a point where that's necessary as well. Now, what can you do about that? Well, one of the things, you don't obsess about the patches. The patches are quantized. So the patients then agonize. I got to put on 3 patches this day and 2 patches that day, and alternate them this way and that way. And I don't do that. I just put on a little bit of gel, and if my next blood draw shows that my estradiol is a little low, I put a little more gel on. And I hadn't been measuring it. And I think that's why it works so well for me. But that is outside of the range of the patch study, because the patch study called it the patch. They named it that, and they worked on it. Early on, they were trying to figure out what was the right schedule. And you look at the later papers I published. I was one author of one of their later papers on quality of life. And I got them to stop calling it estrogen and stopped and refer to it as transdermal estradiol. And not because it isn't any estrogen, and it isn't patches. It's the estradiol per se, not the patches per se, that matter. And I realize I really have drifted into lecture mode, and I may be running all over the map. So I'm going to stop and say, please ask me some questions.
Yeah, I guess one question. I mean, I heard. I guess it was the AnCan video that you did from 2021 about the pulsing. That was really interesting. But now it occurs to me to wonder, what does that mean when you're starting it? Do I have like 0 receptors, or do I have a ton of receptors?
You have a ton of receptors.
Because I haven't had. Yeah.
You have a ton of receptors in the hypothalamus. Okay, and these are sensitive to gonadal hormones, and those particular receptors can be estradiol or androgen receptors. There's some crosstalk between them. But either one, when they have a surge of a gonadal hormone, will change the LHRH signal from the hypothalamus to the pituitary, right? So a high dose of testosterone will shut down the testosterone production pathway, hypothalamus to pituitary to gonads. High dose of androgens or estrogens can shut the system down either way. But we didn't know what the right, myself, I didn't know what the right dose was going to be. So at that particular point, I was getting blood draws every week, making sure that I was suppressing my testosterone without getting my estrogen into blood clot range. And I think that will be variable for for different people. I think you're going to find someone staying with a patch that they're doing fine, and it may be their age. I mean, that could be a variable as well. I mean, just like women vary enormously as to whether they have hot flashes or not, right? They're going to have different densities of receptors in their own hypothalamus. Some of them get no hot flashes, some get a lot of hot flashes, some need a lot of estrogen to control it, some don't need a lot. We're going to be in the same realm. But we're looking for something more than just controlling hot flashes if we're talking about high dose, and that's where it's going to have to be tighter to the individual, I think. Steve, I actually have a very big question, I think, for you. I'm not sure that this is even this is personalizing it for you. And maybe if we post this, you want to remove this part. But when you sent me your notes on your own situation, there's certain things about your concerns about osteoporosis, which are very real. There are other questions there. I don't have a list in front of me. But you're high risk. I assume your post surgical path report state was still 9 or higher. I mean, it was 9 before.
Yeah, it was 9. Still 4 plus 5, not 5 plus 4.
Well, it doesn't matter now because you also have got Mets.
Right.
Right. So that doesn't matter what. But so in that situation, I don't see for ADT itself any advantage of using high dose estradiol. I can't see how it would be any better or worse than any LHRH agonist or antagonist. It would be cheaper. You won't have hot flashes. You'll get some bone protection. And I can talk about all the other side effects as well. But it's not going to be a miracle cure, and you're not going to be the first
case. It seemed to me. Well, here's my reasoning. I don't know if it's, I'm not a doctor and don't have any of that kind of training, but I've read. My reasoning is push the testosterone down as low as it possibly can go, which I've done with Lupron and abiraterone, and then add the estradiol back to deal with some of the side effects of having no estrogen, right? But so that's kind of my reasoning.
So a single patch would probably do that for you. And that gets at your question, is there anything wrong with taking a single patch and going on Zometa, or Nemusmab, I mean, that is any sort of bone protective agent. And I don't know whether that's been looked at, but I don't see any problem with that at all. I mean, women who are premenopausal, who can have osteoporosis and also breast cancer, and if they're treating the osteoporosis, I don't believe they stop treating the osteoporosis just because they're treating the breast cancer.
Right. So that was my guess, that if there had been some kind of a problem interaction there, people would be screaming about it, right? So
and the other part of it, I've had one patient I talked to recently, probably about a month ago, who had a very similar sort of questions, and he is seriously osteoporotic, and uses a walker somewhat, and was worried about a fall, and he is at high risk of a hip fracture or whatever, and he was wondering whether he somehow could just use high enough dose estrogen. But keep in mind that the prostate cancer is osteoblastic, which is paradoxical. That is to say, it actually produces really bad bone because it causes bone to proliferate fast, but not in a mature and stable way with a nice, neat mineral structure that makes for a really strong skeleton. Okay, so and estrogen is osteoprotective, but that's not the same thing. They're not doing the same thing. They're doing somewhat different things. So osteoporosis is prevented by naturally in women to some extent, and men by estrogen, but also by loading the skeleton because that helps it to build its right structure. And when you have METs that doesn't care, it just makes badly constructed bone here and there. So they're really different issues. But again, I would go with what your doctor says because if we're really just trying to manage the side effects of testosterone suppression, there are a lot of things to consider. So you asked about cognitive effect. You asked about, I think, mood. You asked about osteoporosis. You asked about hot flashes. I don't see why a single patch, if it manages the hot flashes, is not a bad idea. But again, got to clear that with your MDs, your medical team.
Yeah, interestingly, so this is, I mean, it's too early for a data point, I suppose, but so I've been on the patch now for 8 days, and until like yesterday, I guess about 48 hours ago, I was still getting about 10 hot flashes a day, and at least one sweat a night. And so then yesterday, I had only 4 mild hot flashes, and today I haven't had a single hot flash yet.
Yeah.
And I didn't sweat last night, so I think the effect has come on for me. It's it's just the start of the data series though, so we'll see.
Yeah, well, that sounds reasonable. But I mean, again, it would make a difference where there's one patch and whether you put it on your scrotum or you put it on your belly. It would make one big difference whether you're a fat person or a thin person. So, but generally, just as the hot flashes start when people start on Lupron after about 3 weeks, somewhere in that range, 2 to 3 weeks would give you time to get control of the system initially, if you have the right dose. So if we're just talking about managing side effects, there's a whole bunch of general things I could say about that. I can't, if you're an abiraterone, why would you, I can't imagine why and you've got metastatic presentation and a Gleason 9 extra capsule extension, et cetera. I don't see any reason to think that estradiol would be better high dose. So I think that's off the table, and we discussed that. Al, you've already been through all that. I'm at that point myself pretty much. I mean, that is, I'm not, if my PSA starts climbing and I'm in castrate resistant, estradiol is not an option. It's not going to, there's no evidence it's going to be any better. Should I say something about managing side effects? Steve, I think this is relevant. So you may not want this, but you alluded to the fact that you used to exercise, but you're not really pushing yourself. And the case for pushing yourself.
I mean, part of it's my I had a hip replacement, and I'm not supposed to run on that, but honestly, some of it's just kind of laziness and not pushing myself like I should. I should be on bicycle more often. In fact, I kind of have to get on the bicycle if I want to go on a bike ride with my brother in Cuba in November, but yeah, I'm not pushing myself like I should.
No, yeah. So here you're agonizing about estradiol. Desperately, you missed. Here's what I think. I'm an amateur. I'm not a psychologist, and so we have one here. John is a real expert. So John, please chip in. You're not the only person. A hell of a lot of people, for instance, during COVID, did not get their mammograms. For my province alone, they figure maybe 300 people died based on the drop in the number of mammograms that were performed during the epidemic, because people delayed getting their mammograms. So not getting an adequate, getting a PSA test can make a person feel really, really, really guilty and damn determined to become an expert But in fact, the most valuable thing you could be doing is not listening to me, but getting on that bike. Absolutely. For control of the cancer, that is, and for the handling the ADT side effects, primarily due to loss of estrogen, um, it will help the bone strength. That's clear. There are other papers by Nick Russell. You can just look up Nick Russell, prostate cancer, Nicholas Russell in PubMed. It's the data set for the U.S. Library of Medicine. You'll find all of his papers there, prostate cancer and estrogen, and it'll bring them up. And he's done wonderful review articles. He's an endocrinologist just outside of Melbourne, associated with the University of Melbourne. And the exercise will probably improve your mood and improve sleep. So last night I had a great night's sleep. Why? Well, I got 12,500 steps in from my exercising yesterday, which is I try to get 9,000 more in per day. But I pushed it yesterday and I slept really well. A good night's sleep helps with your mood. And exercise helps with sleep, helps with the mood, right? And it is difficult to do it alone if you have a friend or something. But if you can't load your hip, and the doctors say not to, I mean, you've got to clear out an exercise program, you head for the swimming pool. But you want to get your heart rate up. You want to be exercising hard enough that it's difficult to sing for sure, and difficult and perhaps even to talk. You want to push it. And there's just been papers published on, does ADT cause fatigue this way or that way? It causes increased cardiovascular risk. One of the newspapers, which I'm not going to do a blog or a tweet on, looked at the histology of the heart of patients on ADT, and it changes. So you got to look at cardiac protective function, and that's going to be to increase your exercise. No reading about estradiol is going to make up for not getting your heart rate up to I don't know how to get this across. Nobody does. Estrogen, exercise is the best medicine we have, but to get people to exercise is a challenge. It helps if you have a social context. So I belong on a dragon boat team. When we get out of the water, we head for the rocks near the beach and we have some beer. So we socialize because we were working so hard. Socializing, you build friends. Building friends gives you a commitment to have to come back to the next practice for your dragon boat team. But that actually publishes with the son of one of the guys about dragon boat in one of the medical literature, the value of exercise and the interplay between social interaction. But so if you're having a hard time pushing yourself, find somebody and say, listen, will you come out with me? And absolutely, I mean, I was never big into exercising, but if I'm walking with someone or walking fast with someone, getting my heart rate up, if I'm talking and I know when I'm exercising hard enough because it's difficult to talk, but at the same time, the exercise is a lot easier because I have something to do besides just walking. I have someone to talk to. So that's the issues as to, whether I'm going to worry about, can I tolerate gynecomastia from estradiol? Should I have a preemptive radiation? That is not going to deal with the fact that you've got to push your exercise up. And I'm being pedantic. John, how am I doing? You're a professional at this. I mean, come on, tell me here. Say something. You're muted.
I just had 4 wisdom teeth pulled out this morning, so these are my first words since I got out of the dentist office. So,
Oh my.
Sorry.
But yeah, absolutely. Thank you very much for emphasizing that.
Okay, I'll go to then a couple more side effects. In the blog entry, there's one of the neatest papers on is estrogen or is ADT, does ADT, standard ADT, cause cognitive impairment? And would estrogen help or not? The literature's a mess. And one of the most interesting papers, some of them have said yes, some of them have said no. There's an increased risk of associated with ADT and long-term dementia. But is that because the people were lethargic, depressed, not exercising, or was it the drugs themselves? And I think one of the most interesting papers I just started to mention looked at subjective assessment of cognitive effects from ADT versus objective measurements. So there's been about 16 papers doing cognitive tests, standardized cognitive tests, looking at spatial processing, word memory, um, uh, prefrontal cortex, executive function type of stuff, all sorts of domains of cognition. And they don't come up with a consistent answer. The majority suggest that there's a loss of visual spatial processing. And on standard ADT, I could not do the computer puzzles that were spatial. I just couldn't. I got back on estrogen, I could. It was amazing how different that was for me personally. However, the group, and I wasn't on this paper, but a group out of Memorial University in Newfoundland has looked at cognitive effects as objectively measured and subjective measures. Ask the patients, do you feel cognitively impaired? And how bad on this scale or that scale do you feel cognitively impaired? And it turned out that ADT correlated much better with subjective measures of cognitive impairment than objective measures. And that sounds like, oh, we're dealing with placebo effects or so forth. But not necessarily. Because, for instance, if you are depressed because you're, I'll use your real numbers. You missed a PSA test and now you're struggling with a world of metastatic presentation, Gleason 9, you have reasons to be scared and not sleeping. Turns out ADT can cause insomnia and depression. Okay? Well, if it can cause insomnia and depression and hot flashes and you're not getting good night's sleep, then you're going to be in a fog, right? So dealing with those side effects, the paradox is they're subjective, but they actually can be addressed. There are interventions. Okay, what is the first best intervention? Exercise. It will deal with, and we can't prove that it helps with the hot flashes, but we know that it can help with the quality of the sleep, which can therefore reduce daytime fatigue, which correlates with subjective sense of a brain fog. So we don't have drugs to treat Alzheimer's disease or cognitive impairment, but we do have things that can help with quality of life. So the big issue here is your quality of life. And yes, it's going to be pushing you. You're going to be sweating because summer's on here in the Northwest. If you're pedaling hard outside or on an exercise bike, but that's the best thing you can do to avoid the cognitive impairment, the sense of cognitive impairment, because the cognitive impairment itself, it can be related to depression and poor sleep. And that's a triad. Depression, insomnia, and fatigue is so common within all sorts of cancer presentations, primarily because it can all be related to depression or poor sleep. And of course, having hot flashes just makes it even worse. So you have a way to deal with the hot flashes, a patch. It's already working for you. But you now got to do the cognitive protective stuff, and we got to protect the skeleton. And you got to load it. The bike doesn't particularly load it. That's a bit of a problem. But you can talk to a gym professional, a physical fitness trainer or whatever, and get some upper body weightlifting or whatever to load your skeleton in a safe way.
Yeah, I've been walking a lot. I do get in my steps. But other than that, I really haven't been systematic about exercising.
The steps again don't help the upper body a great deal. I mean, I have two hips, but two artificial hips, by the way. I would really suggest a rowing machine because you're using full body, you're using your whole body, you're using your arms, your shoulders, your upper body. It doesn't put a whole lot of stress on your hips because you're seated. So there's a lot of good reason. And just like Richard says, I mean, check with your docs and check with your orthopedic guy. But I mean, I was back using the rowing machine within I think 4 weeks of each hip. I think he made me wait 4 weeks, but I was back with that rowing machine.
Whatever your doctors say, or a fitness expert who has real qualifications says you should do, but you'll know because your heart rate will be up, and your ability to sing will disappear. Yeah. if you're exercising hard enough. Okay, so I always throw into talks if I giving them, and this was not meant to be a canned lecture, is you're clear on what most prostate cancer patients die of. Am I right, Steve? You know what is your highest risk of cause of death? Do you know?
Probably heart attack would be my guess.
Yes, right, right. Even with your presentation, you still have a higher risk of death from cardiovascular disease. So everything that gets you into cardiac fitness is what you want to be pushing for. And the benefits are that it will actually been shown to be helpful against advancing prostate cancer. And you don't look like you're overweight, so you already have that as a great advantage. Okay.
Yeah,
Um,
I'm not overweight, but for me, I feel like I'm overweight because I like 15 years ago, I actually weighed 30 pounds less than I do right now. I've always been a skinny guy.
so you're going to push that. What you're going to realize is that you may not be able to bring the weight down being on abiraterone and such.
Yeah, and at
But
my age, I don't want to be 30 pounds less than I am now.
well, okay, what's your BMI? Do you know? Yeah, body mass
I
index.
I don't. Um, I've
It's-
shrunk. I used to be 5'8", and I'm about 5'7" now.
all right. But the um, the exercising, if you're on ADT, for people who exercise in ADT and think they're doing it just to keep their weight down or to fight off the fat, they're missing the point, because what can happen is if they can exercise hard enough, and I've known several people, to actually be able to build muscle on standard ADT. But if they're building muscle, then they're not necessarily going to bring their weight down, right? But also you can be building bone. So we want to maintain the bone and muscle, even if we can't keep the fat down. But everybody sees this bulge. I've got one of them, and it doesn't go away. That, right? That. I think you've heard this. I asked Matthew Smith, a Harvard oncologist, you know, when he asks a patient on ADT how they're doing, and they say, "Well, I'm doing fine except for this," he calls this a positive Lupron sign. So, yeah, I can't. I got it in the few years I was on Lupron, and I have not gotten rid of it over the last 20 years or more. But that's not the issue. You're not doing the exercise to avoid that little belly swell, whatever. You're doing it to protect the bone and muscle, and your mood, and your cognitive function, and sleep quality, and reducing daytime fatigue, etc.
So I want to be cognizant of
Time.
Richard's time, and I do also want to make sure that Al if he has any questions for Richard, and if Dr. John has any questions for Richard. So I suggest we go to Al, we go to Dr. John, and then we'll finish up with Steve. Al, anything you would like to ask Richard about your joint estrogen experiences?
So when I started the estrogen with Dr. Myers, he was very cognizant of that he needed to treat the whole person because he was treating prostate cancer and people were still dying of heart attacks. So he was monitoring me pretty close, including my estrogen levels and everything else. Well, when he retired, the doctors I've seen since then don't know anything about estrogen management, and I've just been kind of on my own. And that came home recently even more because I went to a different doctor to get a fresh evaluation, and she actually measured she measured my follicle stimulating hormone. Is that the estradiol?
No, that's FSH, follicle stimulating hormone, and it's part of the signal from the pituitary to the gonads. But it's getting a lot of attention now because we ask, are these different agents more or less cardioprotective? And the heart has receptors for follicle stimulating hormone as well as the ovaries and so forth. So there's a lot of interest, and you can look up again in PubMed. There's been a big review on the issues around follicle stimulating hormone. And so she obviously knows her stuff. Who is this person, by the way, if I'm going to ask?
Dr. Estefanu at Houston Methodist. But she also said that estradiol was dangerous and I shouldn't be using it. So,
Yes, it is. If you have a BRCA2 mutation and a couple of these other rare, relatively rare genetic mutations, and a family history of breast cancer and prostate cancer all over the map, then it could be dangerous. And secondly, if you're taking it in a way that causes a major surge, right, which we through the digestive system, everything you eat goes directly to your liver for being detoxified before it gets to important organs like your brain and your heart and so forth. And oral estrogens were super dangerous early on, but there's huge numbers of literature already published on the pre the establishment of the patch study. You look up the name Paul Abel, just look up estrogen, Abel, prostate cancer. You'll be able to pull up the papers. So if you ask her, is it dangerous if I take it through a non-oral route? How are you familiar with the patch studies? And I mean, for Rick here and John, I think it's time that maybe there should be how to train patients to ace their consults with their doctors. Don't bring in a whole pile of papers to the doctors. Bring in the abstracts. They can know how to look them up. Don't expect them to read the papers, but they may read the abstracts. There's lots of little tips like that can get you in the right position. But I'll talk to so many patients who want to throw all sorts of information at the doctors or don't know how to respond when the doctor says, well, estrogen's dangerous. Yeah, it can be. No question about it. I mean, but if it's properly managed, this is why I said it's got to be individualized. And if you're going to go on it now. And by the way, I talked to Snuffy Myers. I knew him. I met him at a conference before he died. And Logo Theros just published a paper on overlap syndrome. Is in European Urology, and I published a response to it with Paul Schellhammer, who was a past president of the American Urological Association, because he talks about all of the side effects of ADT, and we need a whole new protocol. And we wrote back saying, well, by the way, estradiol transdermal is there. So it's just a one-page letter. You can look it up in PubMed, pull up my one-page letter. But there's enough stuff out there. That's probably the most recent thing published on transdermal estradiol. And you bring these abstracts, these letters, 3 or 4 of them, say, the doctor, and you present those. But otherwise, the doctors are going to protect themselves, particularly in the United States, where people want to sue other people a lot to say, why will I want to do something off-label? And it is off-label. But I get away with it because I follow an established, published protocol. It's not established; needs to be carefully qualified. A clinical trial protocol that is underway that's already published about 4 or 5 papers showing that it doesn't increase cardiovascular risk. It is prone-protective. It increases quality of life, except for some gynecomastia. And by the way, Steve, there's a paper says men range from I don't want to take any of these drugs if I'm going to develop breasts to I don't care. And it's more sociological, I think, as to how concerned they are. Radiation to prevent, I'm going off on a tangent now, but radiation to prevent gynecomastia has some risk to it. We know this from breast cancer work, where radiating the left breast increases the risk of cardiac damage more than radiating the right breast because the heart's on the left side. So I think there's been a move away from using it, and it also doesn't deal with initial mastalgia, which is a sensitivity of the nipple, but that goes away with time. But I mean, it's something you make a decision for later. Radiation is not effective necessarily. And one MD I published with decided to get a mastectomy, but I don't see that as a particular issue at this time. I have breast development.
I think if I had an issue with it, and I'm given it's going to be low dose, maybe I don't have that much risk. But if
No,
I think I would deal with it with a mastectomy rather than doing a preemptive radiation would be kind of my
I have no breast issue anymore.
Yeah, I mean, again, it's super variable, and it's a socio cultural sort of thing. It's an issue for me. If a patient says, "Oh my God, I've got breasts. I'm too embarrassed. I'm not going to exercise," then we're in bad shape. That's the issue. But there's compressive clothing these days that people wear. You can buy it online. It's standard exercise clothing. It should not be an issue. I'm sorry, Al, I drifted off on that. I wanted to get back to that
Oh,
question.
I just want to comment. I mean, if it were me, I would do a couple of shots or one shot to the breasts. I think it's a better alternative. I've spoken to cardiologists about it, and they don't consider that it has any adverse effect. And it's a much less interventional approach than a mastectomy. Richard, did you say that Snuffy died? Because I hadn't heard that.
I believe he's dead. Al, am I right? Snuffy
I
died? Isn't it
don't,
like,
I don't
yes,
believe he's dead, but I understand he has Parkinson's or
Yeah, he has
Alzheimer's.
Parkinson's.
so
Yeah,
And I
maybe
don't
he
I,
think,
has
I don't think,
Parkinson's, and he's definitely retired. But I think
I
he's still with us, as far
all
as
right.
I
Let
know.
me. I may be wrong then. I'm sorry. I thought I'd heard otherwise. Let me know if you find out.
Yeah,
Let me know.
for
Sorry, I don't
sure.
want
I
to
was going
mislead
to
you on
ask
that.
you,
All right. I'd
um,
real.
Jo-
Let me just say one
John.
more thing about. Oh, God. Go ahead. Go ahead, Rick.
John, do you have any questions you'd like to ask Richard?
I was going to ask Steve what his current weight is. Maybe I could get Richard a BMI on him.
So let's see. So I'd actually lost a little bit in the last couple weeks, and I was measured at 165. That's with clothing. But
That
I
gets
had
you a
been up to about
BMI of
172.
25.8.
So you're a little overweight, but not bad. That's fine.
Yeah.
Uh,
All
Yeah.
right.
I mean,
So
again, it's kind of, you do your own personal comparisons. So I used to be 5'8" and 130 pounds, right? So that's kind of where I was that way for about 30 years.
yeah, that's
And
pretty lean.
all right. I want to answer one more question, and I'm sorry, Al may want to come back on here. More to say. You did ask a cute question. Is there a dose response curve for gynecomastia associated with
Oh,
estradiol?
yeah.
Why it's a cute question is you will not be the first genetic natal male who has asked the same question. And with the popularity of transgenderism, transsexualism now, just about every male to female transsexual finds it a disappointing fact that just
Uh,
taking more estrogen doesn't give them larger breasts, as with women. Okay, who have very variable size breasts and various production of estradiol, you will not be able to max out your breast development. And if that was true, the patch study would have been closed down about 10 years ago. Because,
yeah, hadn't thought about that. That makes sense.
okay. Al, are you having trouble now getting transdermal estradiol?
no, I'm not having any trouble with it at all. It's just
Okay.
that nobody's monitoring it. And I need to find somebody that either has an interest in it or has a background interest, because the oncologists I go to, they're just interested in my PSA and my my PSMA PET test to see where I'm going, and the rest of me, they don't ask anything about. They don't test. I mean, I can ask them to do things, but it can be like pulling teeth to get them to do more than they want to do.
So are you still seeing Logotherapy? Have
No,
you? Oh, okay.
no, I haven't seen Logothetis in a long time.
Well, you
He
might
was
still.
not
So,
he
go ahead.
was not supportive of estradiol.
Well, then you
Which
might add.
probably explains why Eleni isn't a big fan, because she was for many, many years his mentee, but they
Right.
fell out and she went over to Houston Methodist. But that she
Yeah.
probably has some logothetis influence
Well,
there.
I thought it was because it was the first female oncologist I'd been to, and she might have had more interest in estradiol. I don't know.
All right.
I
Well,
have a
Um,
question for you though. Are you managing your ADT solely with the estrogen patch, or are you using, or is it supplementary, and are you on uh, Lupron or something similar?
no, I'm on the patch and Avodart. That was the combination that Dr. Myers put
Right,
together, and it worked by itself. My PSA was undetectable for,
right.
I don't know, 8, 9 years, something
So
like that.
So I want to come back to Richard, because Richard made the comment earlier on that if he started to see and your situation is clearly an aggressive situation where we're managing, but Richard said if he got into that, he would stop using the patch. So I think there's a discussion here.
so
Well,
there's a whole, well, yeah, let me discuss that in a different way, taking Al's situation. Um, if one wants to get on lutetium 177 PSA, it's expensive. You have to pay for it in the United States for sure. It turns out that we have a private clinic here in Vancouver that is trying to compete against Australia, South Africa, Germany, Japan, India. India beats us. It's cheaper. It's still cheaper to fly to India and tolerate the food if you want to get lutetium
Right.
177. But we can compete um, with Australia right now, with Germany. It's a private clinic. Um, and I know the radiation medicine lead for that program.
Okay,
And
we need to talk. I want to stop you because
okay,
this
so
we
it's
don't
gone
need
on.
to talk about this in this discussion, but
Sure.
I have some very, very, very serious concerns about that clinic, and you and I should talk about that
Okay, that's fine. We can do
um,
that. And I'll
offline.
say
Yeah.
that. But ignoring that, edit that out. Um, Personally, and I don't think I want this reported. What I would
Well, hold
probably
on a
do.
minute. If you don't want it recorded, let's
All right.
save that. Save that until we turn the recording
All
off.
right. If my PSA starts climbing and estradiol is not providing control, and I'm heading into castrate resistance, then I would head for abiraterone in combination. And I would definitely want a doublet or triplet therapy. Whether I'd be willing to go on a chemo at that point, I don't know. I'll have to see how I'm doing. It wouldn't matter in terms of what I'm dealing with, in terms of be it, say, depression or bone met pain. I mean, those things would all be variables. I think if I was symptomatic and had pain from Mets, I would be going for triplet therapy personally.
Okay,
But
but
I'm not going to.
the question is, would you do it with estradiol plus abiraterone, or would you switch back to an LHRH?
If I'm not getting control of the estradiol, I'll switch. That,
You would switch.
if I can't
So
not getting control. But if there's
so
other options as well, no.
Al, that's something that maybe you want to dig down into a little deeper using the estradiol like for controlling side effects, and maybe think about switching. I mean, we would say today to Orgovix if you can get it because we think it's a better drug, but this raises a really important issue for you, especially when you're having difficulty controlling your
yeah, well, my PSA is
PSA.
not under control right now. Um, and we've been searching for what's the best thing to do next.
I would
Um,
try Orgovix. I agree with Rick. I mean, I would try Orgovix. I had to fight. We only got it in legal in Canada very recently, and I wrote one of the letters endorsing it as the drug we absolutely should be having up here. And it's an oral drug, and it's expensive, but I would try it. There's no reason why you can't try it. See if it helps. If it doesn't help, you can go back up, and or you have side effects or whatever, you can go back onto stop it. I mean, and then go back on the estradiol. But that's a simple, N=1 experiment that you can do. You're not trapped.
yeah.
And in fact,
Well,
actually,
I've been on Abby plus the estrogen.
okay,
And it worked for a while, and then it didn't work. Then my PSA started rising again.
okay.
When I say a while, a year or two. Um,
And there's some evidence that there's an abscopal effect with lutetium, which means that you could probably go
Right.
try out Xtandi again and you might find that afterwards that it actually gains some effectiveness. So you do still have a lot of options, believe it or not, even post-lute.
You're saying Xtandi and keep the estrogen and add Estradiol.
These are all things to discuss with your oncologist.
No.
But and we had the somehow thinking, because it came up very quickly, that when Pluvecto came around, that this was the best drug and newest thing that's going to cure prostate cancer. Well, it isn't. But at the same time, it isn't the last drug either, because there's now looking at.
And I don't want to say it's the best thing around from my standpoint,
No.
but I want to go back. I think what we're saying is, I wouldn't be thinking, if it were me, I would not be thinking in terms of estradiol and Xtandi for two reasons. The first reason is I'm hearing Richard saying that in an aggressive situation, maybe it's better to use an LHRH drug rather than an estradiol patch. Maybe. The second thing is, we pretty much know that Xtandi after abiraterone doesn't do a lot if you're on an if you're taking it with an LHRH drug. So switching back to the switching to Xtandi may not do anything, but I think if it were me, I would definitely try and see if I got a response from an LHRH. And if you could do it with Orgovyx, you're able to turn it on and turn it off very quickly, a lot more quickly than with a deeper shot. Go ahead, Richard.
There is also the Enzymat study that looked out at using LHRH drug plus Xtandi, and they found that Xtandi alone can be effective. So what one might consider, and so what I'm saying is that you could have an effect that you could bring on Xtandi now after lutetium.
But he's taking abiraterone, Richard.
But he's also he's doing lutetium, right?
Well, I had Xtandi first. I had Xtandi plus estradiol for about 4 years.
And what's happening? Yeah, what's happening is they're now looking at doublet therapy for the really advanced things. They're looking at, hey, wait a second, maybe this works. Maybe the immunotherapies worked after lutetium. There's a bunch of trials looking at what you might want to add after lutetium. And what I'm saying is that we know that Xtandi might actually be worth a second challenge, a second course after lutetium. So these are all things to discuss with your oncologist. Is it worth another round of lutetium? Just like we learned that if docetaxel didn't work, let's go for cabazitaxel. I mean, there's a second round of a taxane drug. So I don't think you should rule it out because it failed earlier, that it will assume that it necessarily would fail the second round. That's all I'm trying to say.
Okay. I stand corrected. I wasn't thinking in terms. I didn't realize you were suggesting that in terms of re-challenging with Xtandi. Yeah.
Anyway,
with an LHRH combination, and Belusic is great. Astathiu is great. So you've got a couple of creative doctors that you can talk to about that.
And on that regard, I think as we're coming to the end here, Rick, I'm happy to talk to individual patients. I encourage them to know about the Life on ADT website, and you're welcome to post something about this. But this is my retirement hobby, if I can offer useful information. But as you know, Steve, I'm not. This is crassly advertising, but this book is part of our program, and the ADT book.
I've got my copy. I was going to see if it's not at hand. It's over there in the other room.
That third edition. Look at the
second edition exercise. Is what I've got.
Yeah, well, look at the third edition because it's better one by far. And it's
Steve, take a little drive up to Vancouver, and you can get Richard to sign it.
I was almost up there just recently, and then the visit fell through. I've got some friends up there, but it's been a while since I was. The last time I was there was 10 years ago for a marriage. But
I live at Lonsdale Quay. I look right out my window at all of Vancouver on the front. I look at Grouse Mountain out the back. There's coffee shops everywhere.
I've walked up Grouse Mountain several times before. That's
All
fun.
right. So, but I'm happy
The
to meet
grouse
with
grind.
patients. Yeah. I mean,
Okay, so
go
can
ahead.
we just decide? I'm going to turn the recording off at this point in time, and then we'll talk about how to manage the recording.